You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Deborah Thorpe, founder and current nurse supervisor at The In-Between, which provides assisted living care for homeless individuals at the end of life in Salt Lake City, Utah, and member of the Intermountain ONS Chapter to discuss ONS Guidelines for Opioid-Induced and Non-Opioid related Cancer Constipation. Deborah was on the panel that developed the ONS Guidelines, which published in the Oncology Nursing Forum in November 2020. You'll find a link to the guidelines in the episode notes. Thanks for joining me today, Deborah.
Thank you for inviting me. I'm happy to discuss this topic.
Just to get this started, why don't you tell us a little bit about yourself, your work in oncology, and your role in developing the ONS guidelines for cancer-related constipation?
I spent most of my career since becoming a nurse practitioner or clinical nurse specialist originally, and in a cancer setting, focusing on pain and palliative care. So symptom management is what I've done for the last 30 years or more. And of course, as being involved in symptom management, I worked a lot with opioids, and it fell to me most of the time to keep people's bowels moving during that. So it became a major focus of my practice.
And how did you get involved in the guidelines work for cancer-related constipation?
Well, that takes me back a while. I was involved in the early formulation of establishing guidelines. I worked on a number of guidelines also between the Oncology Nursing Society and the Hospice and Palliative Nurses Association. So establishing guidelines, being very much interested in research, and particularly frustrated in the lack of research on this particular topic, became very involved in trying to establish a more scientific approach to what we do, or evidence-based.
So let's get right into the topic then. What is constipation prophylaxis lifestyle education, and why was this something that was important to include in the guidelines?
Lifestyle education begins with a thorough assessment of what the patient's pre-existing history of bowel function is, and understanding what their dietary, physical activity, laxative use has been prior to their experience of cancer and being treated particularly with opioids, or receiving some of the cancer therapeutics that are known to cause constipation. So you can't really adequately coach or teach people in lifestyle behaviors without understanding what their lifelong history may have been in terms of bowel function. There's no clear remedy for managing constipation, so it has to be highly individualized based on your assessments, and helping people to look very carefully at what they're eating, what their physical activity is, and how that may relate to their bowel function, particularly before starting them on a bowel regimen.
Well, when you're talking about these lifestyle changes or education, or just even understanding what a patient's previous history may have been, are there specific things that nurses should teach to patients regarding these behaviors before constipation would become an issue for them in their treatment that they're receiving?
Well, it's critical that they understand that constipation is probably the most common side effect of opioid use, and to alert them that they need to pay attention to it and not to wait till it gets to the point where it's so advanced that they become very uncomfortable, and it can be more of a challenge to get under control. So establishing the expectation that they're going to experience constipation is pretty critical to being able to effectively manage it.
I would think that it would be really important for the nurses that are working with these patients to, on a regular basis, reinforce why the patient needs to continue these lifestyle prophylaxis tools, let's say, that they've given to their patients, whether they're experiencing constipation before it becomes an issue or maybe even after it's been resolved, that it would be really important for the nurses to, like I said, reinforce these behaviors with their patients that they're helping.
Yeah, it really is critical, and should be an ongoing assessment with every interaction with the patient, because a lot of people don't realize, they don't think much about constipation. If they haven't experienced it before, it doesn't sound like such a terrible thing, and they'll be able to manage it. But with opioid-related constipation, it can become quite severe, and people can be very uncomfortable. And it is very often a reason why patients won't take pain medicines. They get so uncomfortable with getting constipated, and that may lead to things like nausea and even vomiting in more substantial cases.
What is the difference between osmotic laxatives and stimulant laxatives?
Well, simply put, the osmotic laxatives pull fluid from the body. Usually it's a complex sugar that's not absorbed by the body. So when it's in the bowel, it draws water into the stool and softens it, making it easier to pass. Stimulant laxatives are, just as they say, they stimulate the peristaltic movements of the bowel to propel the stool through the colon.
When would nurses recommend one of them over another?
Again, it relates back to your assessment of the individual and what their normal bowel patterns are. And sometimes it's basically what I call seat of the pants navigation. You try one thing and evaluate how it works. And if it's not successful, you go to another. All along in my practice, I was accustomed to using a combination of the stimulant laxative and a stool softener because the stools can become very dried out. So a combination of something like senna and docusate have both actions. They soften the stool and cause the stimulation. And I found that in the vast majority of patients, that was quite effective. It worked very well. There's some debate in the literature as to whether you need just the stimulant or you need the stool softener, but that's not well researched. We don't have any evidence in our literature that states one is better than the other. So as I said, that goes back to your assessment of what's working for the individual. A lot of times patients don't drink enough water. If they're not feeling well, they may not consume enough water to keep the stool soft, and therefore an osmotic laxative such as propylene glycol or docusate is essential. If someone has used one or the other in the past and it's worked effectively for them, then I would go with what works for them. And then you just gradually titrate the dose of either one to what's working for the individual. And if it isn't working, and you've increased it to a point where it seems like you've given it a reasonable try, then you try switching it up to something else. We don't have enough evidence to say one is better than the other. They're both effective, and they're both on the less expensive side. Certainly senna and docusate are the cheapest. So if you're looking at people, and these are often paid for out of pocket, not covered by insurance, although they may be in some insurance plans, and you're trying to think of what the individual can afford to use on a regular basis, those are all factors that may go into the decision-making process.
Okay. Well, you've mentioned a couple of times the patient assessment, And when we were talking about the prophylaxis lifestyle at the beginning, you also mentioned in that patient history, finding out how they have dealt with this in the past or if they've dealt with it. So, what are some tips or patient assessment priorities that the nurses should use when they're trying to determine what intervention might work best for the patient?
That's a good question. You certainly want to know what their normal bowel patterns are. Some people are very regular and they have a bowel movement every day, or for many, it may be every other day. So you want to determine what their normal bowel pattern is and assess what their lifestyle factors are. For example, if someone, is a young person who's very active and physically active, exercises, runs, and does all of those things, and then they're suddenly ill and they're not able to participate in that kind of level of physical activity, that alone can have an effect on their bowel function. We know from studies done many years ago that just bed rest for somebody can affect a change in their bowel function. So it's important to know what's normal for them. If they have a history of constipation, you can anticipate that it's going to be even more of a problem once they start taking opioids. So you may have to be more aggressive in managing a bowel regimen in an individual who already has a history of constipation. On the other hand, some individuals who have chronic bowel problems, bowel dysfunction, like irritable bowel syndrome, they may find that starting opioids gives them a better bowel movement than they've had in a long time. So it's just critical to know what their pre-existing situation was.
Those are really good points. And I think that it's really important for the nurses to know that those are important questions to ask. And we may not even think about, like you mentioned, someone who was very active prior to receiving treatment. And maybe it was something that by the time the nurse sees them, they have been off of their exercise regimen for a little while. So that might not be something that they think to tell the nurse about or that the nurse might think to ask. So those are all some really good tips on things that the nurse could be assessing for dealing with this side effect.
Exactly.
So we've talked a little bit of how we do the assessment and patients' previous history with constipation. But one of the things you mentioned briefly was patients, maybe they're starting to experience pain, whether that's from their tumor or a side effect in some way. And you talked about receiving pain medication, and that some patients are nervous about that just because of the side effect of constipation that might happen. So, what are some important considerations when you're going to be working with a patient who may be using opioids for pain and preventing an opioid-induced constipation?
Well, again, providing them at the outset with the tools they need to address the constipation, letting them know that it's an extremely common and expected side effect. So if they're armed in advance, they know what to do. To begin taking, my rule of thumb was to tell people if they normally have a bowel movement every day or every other day, that if they haven't had a bowel movement in 3 days, and particularly if they're starting to feel uncomfortable, then they need to start taking the Senna Docusate or the osmotic laxative. And that if it goes to the point where they've gone multiple days, I've had people complain they haven't had a bowel movement in 10 days, at which point you have to be much more aggressive in getting a good bowel clean out and sort of resetting the bowel function to something that is a more semblance of normal before you can really establish a regular prevention routine. So it's important to let them know that they shouldn't let it get out of hand.
Okay. And you mentioned about a bowel regimen. How is one developed? If a nurse has not ever been part of that and now has a patient who is experiencing constipation, whether that's opioid-induced or non-opioid-induced? And is there a difference in how you would develop a bowel regimen for these patients? And what's included in one?
Well, the regimen, as I have noted, can be either stimulant laxative, stool softener based, or osmotic laxative based. I had my preferences just from my own personal experience. It's not, like I said, it's not evidence-based practice. I think it's important just to establish a routine. And if you're working in a clinic setting or a hospital setting, it's a good idea to come up with something that your institution agrees on as is a good starting. Have a suggested bowel regimen established as a matter of patient instruction. Have a handout ready to give patients with suggestions on where to start. And you can offer both types of basic bowel regimens. So just having that ready and knowing that it has to be individualized, that there's a starting point. You start with, usually I started with a senna-docusate combination once a day, moved it to twice a day. If they weren't getting the results that they wanted, if they weren't returning to a normal, comfortable, regular bowel movement, that is what their expectation is, what their normal pattern is. That's the goal. So you have them try starting out with a small dose and then increasing it until they achieve that goal of a normal, comfortable, regular bowel movement. There's no magic formula or recipe that is going to work for everybody. So you have some basic things. And as I said, it's basically trial and error, or what I like to call seat of the pants navigation.
Well, thank you. Can you tell me, in the ONS guidelines, these recommendations that you're talking about that, might be the trial and error that you have to do with patients, are those recommendations listed in the guidelines?
So initial treatment, as I said, is recommended with osmotic laxatives such as polyethylene glycol or PEG, or the stimulant laxatives such as senna and bisacodyl. Although in practice, I have found bisacodyl to be a little bit too stimulating sometimes. Senna seems to produce more normal bowel movements. And that, again, that's just practice-based experience. And so that's the starting point. And for persistent opioid constipation, that you're not getting anywhere despite multiple, and I emphasize multiple attempts at working with these basic laxative regimens to find something that works, then it may be time to consider the PEMORAs, or the peripherally acting mu-opioid receptor antagonist drugs, which should only be used when you've tried these basic things repeatedly. The main reason that those are effective is because most individuals have a fairly large portion of the opioid receptors, particularly the mu receptors, are contained throughout the bowel. And this is the mechanism that is believed to be underlying the problem of opioid-related constipation. So the agonist agents in methylnaltrexone, this class of drugs are effective because we understand that there are a number of receptors in the gut for the opioids. Most notably, the mu receptors are felt to be responsible for what causes constipation. And the PEMORAs, or the peripherally acting mu-opioid receptor antagonists, reverse the binding of the opioids to those receptors in the gut and therefore produce laxation. These are drugs that are certainly more expensive. They're not indicated appropriately for beginning bowel regimens. It should be for constipation that's not been responsive to a persistent attempt to manage bowel function with the osmotic or stimulant laxative and stool softener regimens.
Thank you for describing those and making that a little bit clearer for us. Are there any specific patient education recommendations that nurses should know about when using these agents that you were just mentioning, the receptor antagonist?
Well, first and foremost, they're only indicated for opioid-related constipation. If their constipation is due to another reason, such as in cancer patients, we see those who are receiving certain chemotherapeutic agents, most notably the vinca alkaloids, which are very commonly cause constipation. The Pamoras would not work, would not be indicated for those situations. So this class of drugs is strictly for opioid-related constipation.
Okay, thank you. That's really good to know. So I'd like to ask you, what are some common misconceptions about cancer-related constipation?
Well, I think one of the most common problems that I've seen is that because people do become quite uncomfortable with taking opioids and developing constipation, that it often is a deterrent to them to use their pain medications, and they choose suffering the pain over becoming constipated. And that's very much an individual choice, but I've seen it all too often, and it should never be a reason that someone doesn't have their symptoms adequately controlled. Other things that are key in assessing is what other medications they might be on. Things like the ondansetron is another drug that's very commonly used in cancer patients that may cause constipation. There are a host of other medications in the antidepressant category that can also cause constipation. So it's not only important to know what opioids they're taking, but what other medications are they taking? And that can have a cumulative effect if they're taking, some from each category. How often do you have patients who have nausea and vomiting from chemotherapy? And we use something like ondansetron for that nausea. And they're also receiving opioids. And they may be on an antidepressant medication that is notorious for causing constipation. So all three of those things can contribute to the constipation. And that can make people pretty miserable. And it has always amazed me how some individuals would forego treatment of their symptoms just to avoid constipation. And it wouldn't need to be that way. If you have a good assessment and planned intervention to make sure that it doesn't get out of control. I think we don't fully appreciate how uncomfortable people can be just with constipation. And if it gets to the point where they haven't had a bowel movement in 10 days, they may have nausea and vomiting. They may even have diarrhea because the bowel's natural response to trying to move the stool along in the colon is to the stool becomes liquefied to try to get around the blockage caused by the hard stool. So it's not unusual to have diarrhea as the first sign of really advanced constipation, particularly if there's nausea and vomiting associated with it, and they have not had a bowel movement in many days. And unfortunately, what often happens, a person begins to have some diarrhea, and what do? We give them things to slow their bowel down, and that only compounds the effect. So it's just, I can't emphasize the assessment aspect of this. My first question when someone comes in and complains that they're having diarrhea and nausea and vomiting, and they're particularly if they're on opioids, is when was their last normal bowel movement? And also looking at the consistency of the stool. Are they having diarrhea with small chunks of solid stool? That's an indication that the body's trying to react to the constipation by breaking up the stool the way it naturally does, by liquefying the stool and trying to soften and move it along. So that's not the time to jump in with the agents to treat constipation. It's a time to get the bowel thoroughly cleaned out using a more aggressive regimen of something like the osmotic laxatives and even enemas to try to get the bowel emptied out, reset the whole process, and then start again with a more aggressive prevention regimen.
Thank you. Those are all really good tips and things for the nurses to know. Are there any specific patient education tools or resources that might be helpful for nurses to know about when they're taking care of their patients?
Yes, there are several on the website, the ONS website, and especially the guidelines themselves that also tell you what the strength of the recommendation can be, what the certainty of the evidence is. And you'll see that for most interventions, the strength, the certainty of the evidence is at best moderate, and sometimes it's very low. This is a great opportunity for nurses interested in research to start doing some of this research because it's greatly needed. I would like to see us get to the point where we do more than seat of the pants navigation for something as important as this. On the ONS website has a handout that says, "What can I do about constipation?" that covers the signs of constipation, things that may help with constipation, things to avoid that might make constipation work, and the basic building blocks of a bowel regimen. So this is a really helpful tool that you can adapt for use. You can use it in your clinical setting. And there's another tool called ONS Get Up and Get Moving resource, which is a resource to recommend physical activity to patients during cancer treatment, because we know that physical activity is not only good for bowel function, but certainly for many other aspects of improving sleep quality and managing strength and endurance and that sort of thing. So that's another very good resource to try to help tailor a physical activity regimen that is adapted to the patient's particular circumstances. It's particularly important for someone who has a history of being very physically active and now they're ill and they're undergoing chemotherapy or radiation and they don't feel well. They're not ready to go out and run a marathon, but they need to have some sort of activity regimen that maintains and prevents further degradation of their strength and endurance. So those are two good resources that are available on the ONS website that I would recommend.
Thank you. That's great. And I think that having those available on the ONS website for folks to go back and check into will be extremely helpful for those who may not have had anything at their own institution to help with this. So my last question for you today is, what is something about cancer-related constipation that's not often discussed, but you wish people knew more about? And that could be related to opioid or non-opioid induced constipation.
Well, I think I've really covered what I think is the most overlooked thing is the fact that people will choose not to take their symptom relieving medications if it causes constipation, and they may not even tell you about it. So it's important in your assessment to find out not only how well their bowels are functioning, but how are their symptoms? Are they just suffering in pain and therefore being less active and having a poorer quality of life because they're avoiding taking their medications? That's often in my practice. I experience that far more often than people who overuse their medications, which we're always very concerned about. And, it's certainly a worldwide problem. But the sheer fact that there are people that choose to suffer their symptoms because they don't want to take opioids, sometimes because of the bad connotation of the opioids, but someone who's been very regular all of their lives that counts on that daily bowel movement or that every other day bowel movement to start their day normally, that they may not let you know. So it's important to ask, are they taking their medications the way they need to promote their quality of life? And that bowel function is a very important part of their quality of life. It's not a sexy topic. It's not something people usually like to talk about, so we very often have to draw it out of them. They may not offer it to us, so we need to ask.
Thank you. I think that's a really good kind of final piece to encourage nurses to make sure that they are asking those questions. And I agree with you. I think that it's not something that patients are going to just readily give you that information. And we do have to ask very directed questions to them to be able to help them so that they don't have issues with their quality of life and with this side effect that could very well be controlled and managed for these patients.
That's so true. And we need to remember their focus is going to be on, what's going to happen with my cancer. They may not be as worried about their bowel function as they are, what kind of cancer treatment am I going to have? What are my odds of success? What's my prognosis? Those are pretty serious questions that they're facing. And so the whole issue of something like bowel function may just completely drop off their radar when they're being seen for follow-up visit. So it's important for us to ask.
So just to wrap us up today, do you have any final comments about the new ONS guidelines for opioid-induced and non-opioid related cancer constipation and its role in patient care?
The most important thing I think needs to be said is that the work that we've done for this guideline clearly points out the need for much more research so that we can develop have stronger evidence for a practice. A lot of the things I do because I've seen them work in practice, but I can't say with any certainty that this is what you should do in the majority of cases. We really need that evidence-based practice. So this is an area, if you're interested in developing some research or even some quality improvement projects, that this is a great place to start. We need more evidence.
Well, thank you so much for joining us today, Deborah. This has been very informational and educational for me and for the nurses that are going to be listening in on our podcast, and will then go and look at the ONS guidelines and hopefully start implementing what the work that your guideline team has done to get into practice and into how they care for their cancer patients. So thank you for sharing with us today.
Thank you for the invitation. I'm always happy to talk about something that's near and dear to my heart.
Well, thank you. Have a wonderful day.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.